Our first speaker, Professor Kelvin Kong. He's a paediatric adult otolaryngologist. A head and neck surgeon at the John Hunter Hospital. Professor Kelvin Kong is a leading ear, nose, throat specialist with a deep passion and long-standing practice in addressing the ear health for Aboriginal children and ensuring that all children have the chance to listen and to hear their teachers, families and friends. Professor Kong is a proud Wurrumai man from Port Stephens, and we are thrilled that he's able to spend some time with us. Kelvin.
I wanted to start with a video which some have seen already, which is just trying to outline the main issues that I wanted to talk about.
We must look after each other. Warala. Unjawal gingarme kanyan muninjuram garmane. Ngacak paninger, kacanak, muning dragonfly, kagamak, kaginjil mamak, bintunje, peraking ura kebenjira, muniyong, nijil gumak, king urak, muniyong ma, genjem makane.
We are a very oral history nation. Aboriginal culture is passed down through oral history, storytelling, gatherings. And so part of this storytelling time is being able to hear. It is so important to our culture. Unfortunately, Australia still has the worst ear disease rates in the world. Chronic suppurative otitis media is where you're getting discharge out of the ears. The World Health Organization say it's at problematic proportions when it reaches 4%. In Australia, communities vary from 40% right up to 85% of chronic suppurative otitis media. It is appalling that we live in this dichotomy where a first world country has third world health statistics.
I have 6 daughters. Out of the 6 daughters, 3 of them suffered from ear problems. So they learned to lip read, body language to get them through.
The long-term effects or the consequences of ear disease, lack of work, substance abuse, lack of education, all these things all stem from the very crux and the initial part of otitis media, not hearing.
We learned to live with it, I guess. And with my brother, like I can talk from experience there with him. You know, I took him to school all his life, and I've seen his struggles throughout school. Tools for life, but you know, that's what we taught. Tools in life to get through life, and that was one that he missed out on because of that. He wasn't able to. You learn. You only taught what you learn, and if you're not hearing, you're not getting the right message. That's all you know.
Iyo kuning cakka ngurak kuning nyal ka kuning kuriyo ngone nyal kan yang ngalngan ge bin peni ngone kanyan kuning king ngurak ma kuning kanyang.
When we look at some of our Indigenous kids and what the ear disease they get at a very early age. So normally around the 12-month mark we're talking about. In normal population, you're seeing it around 2 to 3 years of age. At 12 months, we all know the first thing babies are doing is listening. They're listening, they're babbling, they're starting to talk. So language gets affected. So by the time they even start going to preschool, they're about 2 years behind on their language and social skills.
Because I've been through that with myself, with my children, and now with my grandson. And it's hard in trying to learn and try and tell people, you know, I'm stupid, you just got a hearing problem, I can't hear you properly.
If I'm sitting there and like I ask the teacher like to repeat it and she says it again, like, and I might ask her again and like she thinks I'm being smart.
They're not paying attention. They must be misbehaving. If they're misbehaving, rather than bring up the front of the room where they can hear, they're put up the back and they're taught the naughty kids. So they end up being class in a group which is not where they belong.
Self-esteem just goes right downhill. Oh, well, I just run with this crowd here. I'll be part of a crowd. I can't be part of that crowd because I know nothing.
Then they start mixing into petty crime. Petty crime, you can't pay the bills for petty crime, but you can't get the representation you need to. So then these people get incarcerated. Incarceration rates, as we know, in the Aboriginal population are up toward the nearly 30% rate compared to our population of this nation, which is 3%. Now, how can that be so overrepresented? When you talk about a sliding doors moment associated with this, at any time in that spectrum, if you can correct the hearing loss, then you're always going to move yourself on a better trajectory. So what if we met a prisoner who was incarcerated and we got their health records out and we traced it back to see when that ear disease first started? I've no doubt you'd find it starting at 12 months, 18 months of age. Around $600 million of Medicare dollars is being spent on otitis media in Australia. That shows you how big the problem is on treatment, medications, time off work. As a taxpayer, you should be offended by the amount of money that we have to put in at the end of the spectrum when the dollar put in at the birth or early stage of things is going to rectify this whole situation.
The strength of us in our spine is about our culture and our Aboriginality. People want to learn about the past, to live the present, to make a future. And some of those kids haven't got that.
Language and culture is the cornerstone of a person. When they find the importance and the value of their own culture and their language, it actually opens them up and makes them feel valued.
I asked the Prime Minister, what if that was your child and they weren't hearing that well? What would you do to make sure they heard well and got the correct education they required?
Unamji Ombarawalchan, your Marvel Mugan, Yani, Marajuroma, Yabla,
I think that's a really nice introduction because I don't have much time to talk, but it really epitomises some of the things that we talk about in this kind of paradigm that we live in. Quickly want to acknowledge country as well, and also a lot of my mentors. I'll try and rip through quickly because I'm not actually going to solve any problems today. I'm really here to raise issues that I hope we can create conversation around, because I think sometimes some of these issues aren't talked about and therefore we don't actually get to the crux of the problem. Rather, we talk about different ways that we silos rather than thinking about the big picture stuff. But this is the kind of picture that we're looking at. This continual story that I see where kids are facing the wrong end of the spectrum, where they're having long-term ear disease, where they're not hearing, where they're not getting all their education, where they're not getting the health, where there's family politics going on, where there's all these other interpersonal issues going on that we just think hearing, and it's more than that in a whole raft of things. And these are the kind of pictures you see with the ear disease, with the perforations that are occurring. And we get this kind of circle of life that occurs, and the circle of life is the wrong circle. There's different iterations of this kind of picture, but it's pretty much being born into a world of poverty, being born into a world of poor social determinants, being born into a world where you're actually set up for failure. And all those things in the middle there in pink are factors which play a huge role in this that we need to address collaboratively to actually make this work. And each part of that, we have our own area to look after, and each part of that we need to advocate very strongly for. And that strength of our advocation in this area means that we need to be able to work together. I think too often we work in silos associated. This is a really important slide, and this is a really important slide about the language acquisition, but also your cognitive function. And it's the first years of life that this occurs in. And for far too long, we've been looking at school age and saying, well, are they hearing when they're going to school? We've missed the boat if we're looking at school age for hearing. We need to get onto it within the first 12 months of life and actually follow this through, not something that we miss out on later on in life. And this is from what we always talk about, Coolamon to ashes, where it's a whole spectrum of disease, but we need to catch it early to try and make that better. This slide I love because it really talks about the responses, sound, and sound is not a click, it's far more than that. There is all this part, and that's where I love that short film clip of it, because it really shows the power of the music, of the storylines, of the interaction, of the engagement. And I think the second part of that, which is the lower point there, is that in the arguments that we have, we fight too much over what's going on, and ear disease is not just a public health policy either. We can't have one play off on the other. They have to work in synergy. And often we hear about the social determinants of health, which are very important, don't get me wrong, but it cannot be at the expense of looking after these children who need hearing rehabilitation to make sure that they're learning well. And they must work together, not in silos. So when we talk about the emotional side of things, we don't have a lot of time to go into. Simple music that changes your mood to make you happy, to make you smile, to engage at. It's not about a click, it's not about a sound, it's about enjoying things. And you can see half the room smiling already just by this thing called sound, which is really interesting and it's really nice to see that. Yet the disease process precedes this kind of process here where fluid's getting into the drums. And more so in Newcastle, we're not talking about remote areas here, we're seeing the kind of disease process extrapolate to the very severe end of things. So we're not talking about just an otitis media with a big glue ear. This is a maggot in an ear in Newcastle, where you're seeing the disease spectrum being proliferated so bad because there is no access to health. In an urban setting, eastern seaboard of Australia, busy hospital where there's about 5 different tertiary referral hospitals around the area. Horrible thing to see. And then the other part of that then is the reality of what we're dealing with in the context. And it is, when you look at this referral that was sent to me, you can see, okay, that's okay. You can see up above the date on the right-hand side there and the way in which it's referred to me. To try and get a quicker appointment, and the racism there quite obvious. This is an audiologist who spent 30 minutes in the room with a kid trying to take a hearing test, and this is a... Now, if this is my kid, I'd be absolutely appalled. And that's the overt part of it, which we see, and we see it still quite often, but we don't see the implicit aspect of it as well. And the implicit bias of all that is the access to surgery. In Australia, the MBS report done last year shows that your health, particularly ear health, is predicated on your postcode. If you live in a wealthy suburb, whether you're public or private, you're going to get access to healthcare. If you're not, good luck. And so it's fine for us to not sit here and just talk about these things. And here's the problem. This is a graph put together by Deborah Lane, which really looked at the complexity of ear disease. It is not easy to look after. It is a really, really, really complex problem that needs multiple solutions associated with it. The point of being there is that we want to see this simple picture. A non-Indigenous kid, an Indigenous kid, both my patients, why do we know just looking at this photo that they're going to have 2 different health outcomes, they have 2 different employment outcomes, they have 2 different lives? Again, predicated on their postcode, not by what they should be, which is living in Australia as an Australian child. And there must be an easier pathway. And we look for these things called distractors. They're great words to use. The 2 great distractors that we've seen in recent years is Kodak. Kodak had a future meeting talking about how film's going to go out and they need to get in the digital era. They pushed all those people out of the room and said, we don't need this, film's the way to go. Nowhere now. Qantas, their distractor was trying to get the cost down. They couldn't do it with it. They brought Jetstar in. Distractor, changed the whole airline industry and the cost that it's doing there. And so there must be ways in which we can actually look at these as distractors to try and change the way in which we're going. We can't keep putting money in the way we're doing because it's not working the way it is. The refresh is really hard because government is actually hamstrung by what they can do, and government's hamstrung by what I feel is a lot of rhetoric. Bureaucracy is really tough to get through. Trying to get policy done at a state and federal level, we still battle with. And all of us that work in the NGOs, all of us that work in hospitals know how tough that is. So it's really important for us to actually look at that bigger picture to make sure we have the synergies. Aboriginal health in Aboriginal hands is very, very important, but we can't have Aboriginal health in Aboriginal hands if we don't have the diversity in what we're trying to understand here. And we say that quite a lot, and it's probably a challenging thing to say. But if you're Aboriginal and you're not near health disease, then there's no real point being in this space and putting your hand up when you're not really talking about disease. And so we need to make sure that we've got the right advice around that. The eHealth for Life group is a wonderful group, and I encourage everyone who's not involved in this group to get involved in this, because it's a really good Australian network of a whole diverse group of people which can actually help in this space. The public health approach is extremely important. I can't stress that, even though my next point says it's not expensive acute treatment. There is a primary and a tertiary healthcare referral system. The primary is where we need to work harder on, but we can't do that at an expensive tertiary referral because all these kids are missing out on all the treatment they require. And it's a really important point to say, and every time I talk about primary health, because I'm a big advocate of it, is that we must not forget that we need to treat those kids as well. And we really need to have an outcomes-based health impact assessment to make sure what we're doing as well. It's no point pumping millions of dollars into stuff and not seeing any outcomes. We talk about evidence-based medicine all the time, but we don't have as much stringent policy around evidence-based policy. We need to hold the policyholders accountable for what they're actually providing funding for. And I think a lot of projects I'm involved in, guilty as charged, don't work all that well. So we're always trying to reiterate and change that, but we need to actually look at that. And so what we need around this is a national strategy. A strategy to look for a group of people who are keen on this area, actually make a difference. We need a collaborative approach, and I can't stress that enough. It has to be between federal, state bureaucracies, universities, academics, clinicians, audiologists, speech pathologists, teachers, justice health. All these people need to be involved. It can't just be a health issue. It has to be an issue involving everyone. That we need to set the standards that are appropriate, that we think is good. And that standard is a simple standard. If this is your kid, what would you want done? That we need to have guidelines, accountability, and as I said before, this is no longer an area that we can just say this is going to work itself out. And there are so many things that are across that sector. And we've got to move away from those silos, importantly, that we talk about all these other things and we work together to make sure that we're covering off all those. And some of the things we're doing now are actually improving on that. Justice Health is starting to work with education, starting to work with health, which is actually really nice to see, but it's taken too long to actually get that. And we need to, as a society, hold the government and the fund holders accountable for this. Because at the end of the day, these are the kind of pictures you want to see, the interaction, the engagement, the fun stuff, which is going to change the outcomes quite differently to what we're expecting at the moment. And what we see in this, which is really sad, is that when we do these presentations, and deliberately why I put this, is it's always such disparity, it's always such negative, it's always so sad. Whereas this is a picture I want you to go home with, because this is the engaging stuff that we do where the kids are smiling, they're happy, they're interactive, they're participating, they're doing so well in school, which is the way that we want it to be. And so for my last slide then is I think it's important that we put ear health front and centre of all this. And I know I'm biased with this, but unless you're hearing, you can't do anything else. And that's really important for that. We need to have a national strategy to embed all of these important aspects of it. And we need to make it evidence-based no matter what we're doing. And it has to be embedded within the community where the community actually come along the journey. It's no point us as health professionals saying this is what you need. Thank you.
Well, thank you, Kelvin. While you're up there, are there any probing questions or comments from the audience, or Tim, do you have any online?
No, not on Zoom.
Yes. Okay. Who's going to run the microphone around?
Hi, Kelvin. I think you know what I'm going to say. Why is it that New South Wales Health has stopped the OM screening in all of New South Wales? I work in Western Sydney Local Health District, which has the largest population of Aboriginal and Torres Strait Islander people in Australia, but yet we can't do any sort of screening for Aboriginal children whatsoever, unless they go to a nurse audiologist that has a waiting list, but that doesn't alleviate the problem. New South Wales Health has a lot to answer for. They've stopped that. What's it been now, Tracy? 10 years?
I think it's hard. I can't answer for New South Wales Health, so I'd move away from that. But I think what I need to clarify is that there are a lot of work going on around getting key performance indicators, and part of that process is actually getting the data collection. So on the separate screen, we're getting the newborn hearing, which is one of the best in the world, and actually copy. We're hoping to work on that database to actually extract, and there's some stuff going on with Hearing Australia with the Early Ears program, which is starting to reiterate what we need to do to get appropriate screening and appropriate screening at a very early age. So watch this space, and then it's a matter of us getting that right and then bringing the states on board, because it's not just New South Wales Health. There are other states that are...
How are they going to get the data if there's no screening?
Well, that'll be part of it, is you've got to work out what's the appropriate screening to do. And then when you know what the appropriate screening to do, because the 12-month-old is very different to a 3, 4-year-old. But you're absolutely right. Can't agree more.
And I'm sorry, my name's Linda Lewis.
Okay, any other questions or comments? Paul?
Hi, Paul Higginbotham, Airbus Foundation. Just to follow up on that, and I'm going to make a statement, not a question, but the Auditor General just produced a report in Western Australia which evaluated the performance of the Health Department, WA Country Health, Child and Adolescent Health. They've all been screening for decades. They haven't got a single scrap of data. Nothing. They've got absolutely no data. So you can screen all you want, but it's not the screening, it's what comes next and monitoring the data. So,
well, the states do have a secret collection of data, but that's what we're trying to get out.
I should have said earlier that we're very, very proud that Kelvin was our first Aboriginal Trust Element surgeon, and particularly ear, nose and throat. So well done, Kelvin.